Okay, well, I'm Gus Cairns. I'm features editor at NAM, who run the AIDS information site aidsmap.com. I'm also a member of the European AIDS Treatment Group, and I'm involved in a couple of clinical studies and prevention initiatives. I'm the patient rep on the steering committee in the Child Microbicides Research Consortium, and on the PROUD study, which is the UK's study of pre-exposure prophylaxis. So that's my professional involvement. My personal involvement in HIV is that I've had it for, gosh, I'm just trying to work it out, nearly 30 years, since 1985. So that's been a very important part of my life, but not my whole life. I basically ended up doing the first thing at the conference and the last thing at the conference. The first thing was the satellite symposium on microbicide development in Europe, which of course is a very important but very specific aspect of HIV prevention, something we're hoping will add to the resources we've got for presenting HIV in the future. The last one was a much more general panel discussing the use of antiretroviral therapy as prevention in general, how we could extend it, how we could make it work better, how we could get enough people on the therapies in order to bring down the infection rate. That was a very interesting discussion because it's not simple. It's not as simple as it might sound. We think that, we know that if you put people on antiretrovirals, you'll make them less infectious, but it's not always that easy. In a paradoxical way, this is working better. One study, not at the conference, but that somebody mentioned at the conference, shows that this is possible in Africa, where people tend to be much more long-term infected, and are infected much more through long-term heterosexual relationships. In Europe, it's difficult because people tend to be infected by other people who've just been infected themselves, so it's difficult to catch them in time. And that includes both amongst gay men in Western Europe and injecting drug users, particularly in Eastern Europe. So that was interesting. I wouldn't say this was a conference at which there was any revolutionary news announced. It's more sort of interesting behavioural stuff. The revision of the European guidelines was interesting. Not so much because they drastically changed the treatments they recommend, but more because of a sort of change in philosophy, you might almost say. Some of the guidelines, the American and French ones, say just treat everybody as soon as they're diagnosed. The European ones, and although they're a little bit out of date, the British ones, I think their philosophy is, well, patients need to be ready. Patients need to be ready to take treatment. There's no point getting your patient who's just been diagnosed with HIV, probably very shocked, feeling very stupid, whatever, and say, here's a bottle of pills, take them. Some will, but equally some won't. So you have to get, patients talking about it. And that particularly applies if people have reasonably high CD4 counts and are reasonably still healthy, as they often are. And so what the European guidelines used to say was, people who have CD4 counts over 350 or whatever, just defer the treatment. Don't even talk about it yet. Well, they decided that was wrong, and that really you should consider treating anyone. But for people with over 350 CD4 cells, it's not so much to give a strong recommendation to the patient, but to generally discuss all the pros and cons of treatment. And if they want to take treatment, which may, for instance, be for prevention reasons, because they're in a serious discordant relationship or they just want to protect sexual partners, then yeah, sure, go ahead and do it. So it kind of says consider treating everybody, but it doesn't sort of mandate or recommend it. That's the difference. Other than that, I think a lot of the most interesting studies, apart, there's a bit of a sort of pause in the development of things like the hepatitis drugs. They're still very interesting, but we haven't got them licensed yet. There are other drugs coming. There's a trickle of new HIV drugs coming along. But I think the most interesting stuff at this conference was more the sort of behavioural stuff, the kind of increases in things like the use of recreational drugs in gay men and the strong relationship that has with unsafe sex. But there was some good news as well. There was a terrific study that I'm just writing up from British Columbia that shows, it's not unexpected, but it shows a hugely declining suicide rate in people with HIV until it's more or less reached general population levels now. Now, suicide is a depressing subject. People don't talk about it a lot. But it used to be a considerable cause of mortality in people with HIV. I know people who've killed themselves. And that it's declined so much, 35-fold between 1998 and now. Incredible. Is a testament to the fact that people with HIV now feel that life is generally much more worth living. So that's been interesting. It's been an odd conference for me in that I'm normally a reporter, and for the first time I've spent more time making presentations than reporting. On a personal note, I think Europe in the West has a record of HIV treatment that's second to none. We get more patients on antiretroviral therapy, and we keep more of them undetectable than virtually anywhere else in the world, and that's great. Some countries also have high testing rates as well. France is as good as the United States, although perhaps others, like the UK, doesn't quite get people testing often enough who need to. In the UK, the recommendation is that gay men should get tested once a year, and really that's not often enough if you're running risks. In Eastern Europe, they test a lot of people, but then they don't do anything for them. And I think it's a very different situation. Eastern Europe has one of the most disastrous rates of access to treatment in the world, and it's not that the drugs are not there. It's that the health systems somehow don't work to get people with HIV on those drugs. They're inefficient. Presentation by the Ukrainian Association of People Living with HIV said they're not just inefficient, they're corrupt. Drug money goes to, politicians. And also there's huge stigma around. The kind of people who get HIV are the kind of people who meet up with very stigmatizing attitudes from healthcare staff there, And also, services are not integrated. So there is a TB service, but it's not in any way integrated into the HIV service, which is silly. And of course, we can't ignore the fact that in some countries, groups vulnerable to HIV, injecting drug users, gay men, are criminalised and highly stigmatised, and there's been so much additional anger and pressure in the media about them recently. That's not helpful. So I think there's a long way to go. It's notable that although it's the European AIDS Clinical Society, I couldn't find a single clinician from Eastern Europe in the guidelines writing group or on the EACTS board, and I think that's a real omission. I may be inaccurate, there may be one or two, but there's certainly not many. And yet the activist organisations like EATG have really good representation from Eastern Europe, so it can be done. And I think there needs to be more integration with East and Southeastern Europe and the countries that have much less good access to therapy.